Good evening and welcome to the Roselle Center for Healing's ongoing webinar series. I'm your host, Dr. Harlan Browning, and tonight we'll be talking about diagnosing and treating the complexities of joint pain, a conservative approach. We'll look at three of the most common reasons that we have joint pain, and hopefully by the end of the evening, we will give you some conservative options to treat these. The topics that we're going to go through tonight include knowing what your pain type is, and I include this in a lot of my presentations. If you know your pain pattern, it really helps you understand where it's coming from and ultimately gives you an idea of how to fix it. We'll look at pain pathways in the body that are caused by inflammation. By the time this evening is finished, you're going to really understand that inflammation is pain and pain is inflammation. So very important topic. We're going to talk about the three common causes of joint pain and the subsets that fall underneath of that. We're going to talk about testing and confirming your condition, the laboratory tests, the MRIs, all the other tests that help us give a further diagnosis. We'll look at acid-alkaline dieting, how a diet impacts inflammation and ultimately changes our pain. We'll specifically talk about nutrients for healing, anti-inflammatory nutrients, nutrients to control immune response, and nutrients to modulate hormones. And also, we'll touch on what I call the 7 steps of success. And I put this slide in a lot of my presentations because it has a lot to do with just being healthy overall. So the first thing that we're going to talk about is knowing your pain type. You have to ask yourself, is your pain acute? Did it just start, or is it chronic? Has it been going on for long periods of time? Is your pain isolated to one area, maybe your knee, so that would be local? Or is it global? It seems to affect most of my body. Was there an injury that started the problem, or did the pain or issue just come out of nowhere? Is your pain constant? Is it always there, or is it episodic? It's sometimes there and sometimes goes away. Is it provocative? Can I make it better or worse? Or is it relatively stable? It's just always there. It doesn't get better, doesn't get worse as time goes by. And lastly, is it age dependent? Meaning that are we noticing more and more things happening as we get older? And a lot of you are probably saying, well, that makes sense, but not necessarily. Some folks age gracefully and others don't. So we have to look at the effective age and how inflammation impacts that today as well. Let's talk about what pain is. By definition, pain is defined as an unpleasant feeling that is conveyed to the brain by sensory neurons. This discomfort signals actual or potential injury to the body. So it's a subjective feeling. When I have a patient in my office, we'll often ask them what their pain scale is. Give me a number where your pain lies. Is 0 means no pain and a 10 is the hospital. A person might say, well, doc, my pain is a 9. And another person might say, doc, my pain is a 3. Well, that's a perception to them. So we have to use that as a kind of a loose network to which we can give a diagnosis, but we can't just put all of it on the person's subjective component. As I said earlier, pain is an expression of inflammation. And as research progresses, as time goes by, we see this more and more. There's inflammatory mediators. These are substances produced in the body that cause us to be inflamed. And these mediators ultimately cause us to have pain. The question I always get for people is inflammation good or bad? And the answer is both. We need inflammation to tell the body to repair. But the issue becomes when inflammation is propagated over long periods of time, it becomes counterproductive and what we call catabolic. It causes the body to break down and unnecessarily use reserves, things that are stored, nutrients, and all of those types of things. So inflammation is important. It's chronic inflammation or out of control inflammation that becomes problematic. So pain is also propagated by tissue damage, and we call that nociception. So if I twist my ankle and I damage the ligaments in my ankle, I'm triggering specific nociceptors. These are like little tiny gauges in my ankle that tell my brain that I have pain. Well, in certain cases, it can be just because we activate a nerve, and we call that neurogenic. The classic example would be diabetic neuropathy. The blood sugars accumulate in the nerve, they sensitize it and activate it and cause it to fire and give us a perception of pain. All of these involve what we call chemical messengers, such as cytokines, neuropeptides, growth factors, and neurotransmitters. These are messengers that tell one part of the body what's going on in anticipation for that part of the body to maybe help control the situation, repair it, and do what it needs to do. So these messengers are extremely important. The control of these messengers is what we're going to talk about today, because if we can buffer those or keep these messengers within a certain line of check, then inflammation is held in place. When we're in pain, we initiate the autonomic concomitant system, or the sympathetic nervous system. That's why when you have pain, let's say you hit your thumb when you're hammering and you feel pain, but you might also feel nausea or you might sweat. Well, that's because those pain fibers are communicating with the sympathetic nervous system at the same time. So for some folks, they have a lot more of these autonomic sensations than they actually do pain. And we'll talk about how the sympathetic and parasympathetic nervous system feeds into this pathway. And ultimately, with time, pain causes plastic changes in both the spine and the brain, and it leads to what we refer to as centralized sensitization. These are big words that mean that as the body continually experiences pain, it rewires itself to make it easier to experience this pain. So this is a self-defeating system. And as time goes by, then the brain gets caught up in this and it actually will help feed into it. We see with imaging of the brain that folks that have chronic pain syndromes, their brain actually shrinks over time. That's part of the plasticity. So when you break the pain cycle, you ultimately help prevent the brain from remapping itself. And for many folks, that's the reason that they have chronic issues or chronic pain syndromes like fibromyalgia. Today we'll talk about what I refer to as the 3 common causes of pain, and there's going to be subsets underneath of it, but they more or less fall into these 3 categories: mechanical and degenerative changes that take place, metabolic and inflammatory conditions, and I put in parentheses comorbidities, with meaning, like, let's say for example diabetes. Unchecked diabetes can cause a lot of pain. That's that neuropathy. So some folks don't think about their morbidities that they already have. They just think about the injuries that they sustain. And lastly, we'll talk about different patterns of referral of pain from different parts of the body. So the first one is mechanical and degenerative changes. These are the ones that most people are aware of. These are the overuse injuries, the tendinitises and the bursitis. This is the acute trauma. This is the sprain, the strain, I twist my ankle. And these are certainly the degenerative conditions, the osteoarthritis, the wear and tear of discs, and all of those different mechanisms that take place as time goes by. As we look at them one by one, specifically here, we'll talk about tendinitis versus bursitis. On your left-hand side for the tendinitis model, we can see that, and let me pull up a marker here. Let's do this. This side is a normal cross-section of a tendon. And here's our muscle that goes into the tendon, and the tendon is bound up by a series of connective tissue, and inside of it are little tiny fibers that go all the way down to bundles of collagen. So when they're healthy, all of these systems have good elasticity. They can stretch. They can handle a lot of abuse. As we overwhelm the system from what we call an overuse injury, that's like playing tennis or doing repetitive activity, these collagen fibers start to break down. And as they break down, they start to reheal by putting down what we call fibroblasts. That's scar tissue. So as the scar tissue is laid down, it causes the problem to exacerbate and continue. So the scar tissue more or less just spreads over time. So in these types of overuse injuries, the body is causing inflammation and is repairing. It's causing inflammation and repairing. So it's an on and off of inflammation over long periods of time, which ultimately leads to the formation of scar tissue. Similarly, here on the right with bursitis, the bursa is a fluid-filled sac that sits underneath of a muscle. Okay, and this looks like it's a finger bone, and this is looks like one of the extensors of the finger. And underneath here is a bursa. So it's a buffer between the bony structure and the muscle above. What happens is, as we activate the muscle over and over again, then the bursa gets irritated and it physically inflames. And as time goes by, in some people it can get quite pronounced, can get large. So the mechanism for the tendonitis and the bursitis are relatively similar as far as overactivation and taking the tissue beyond its natural capacity. The difference is in the tendonitis, we can see a physical change in the tendon. We call that a tendinosis. It's actually dying. And in the bursitis, we actually can see that the bursa gets inflamed and swells. The end product is we have pain at the joint. So let's also talk about acute trauma, because this is a really important component for a lot of the athletes out there. When we have a trauma to any area of our body, it usually involves what we call blunt force trauma. We either has a contusion or we physically derange or tear something. In this case, on the right-hand side, it looks like this person is torn their meniscus. The problem with the contusion component is we go through and we damage a lot of soft tissue when we do that. Not only in this picture are we damaging several layers of the quadricep muscles, but on the outside of all this is the fascia. So we're damaging or irritating the fascia, which is the connective tissue that holds us all together. As we damage these muscles, they have a tendency to swell, and because they're all in separate compartments, and you can see these lines that demarcate each muscle group, as they swell, they have a limit to how far that they can go outward. So in some cases, it can cause what we refer to as a compartment syndrome. There's no more room for it to stretch, and then it starts to put internal pressure on the nerves and the blood supply within. The end product is a person usually has a serious amount of pain, definitely has bruising and limited capacity. Now, for the person that maybe tears a meniscus or tears, let's say, the internal structure, the ACL or the PCL, these are ligaments, strong ligaments in the knee, the person might not have a tremendous amount of swelling, but they certainly are going to have a lot of pain. The cartilage within the joint and the ligaments within the joint are somewhat avascular, meaning that they don't have great blood supply. So the speed in which they heal is a lot slower than, believe it or not, this person who's had a contusion to their muscle. And that's why athletes, let's say, who tear their ACL, it's usually a 6 to 8 month recovery process from start to finish. Again, because the blood supply is really poor. The issue with as far as what I see with cartilaginous and ligamentous injuries is the person usually keeps on pushing through these and causes further damage, and they don't necessarily know it. The problem on the end is if we start to develop an impairment, not only is the knee painful, but now it feels like it's giving way, or if it's clicking or popping, that means that the tissue has been deranged so much that it is compromising normal joint function, which ultimately can cause, believe it or not, bursitis and tendonitis and all those things. Well, this is probably one of the bigger components of why folks have chronic pain, and it's just old-fashioned degenerative conditions like osteoarthritis. On the left-hand side, we see a person's lumbar spine, and this is the disc that sits in between. So this one is a relatively healthy disc. When the disc has good volume and it's not been damaged, then it separates the vertebrae above and below, and that allows for a nice big opening where the nerve exits, called the foramen. When the disc degenerates and it gets smaller, then not only do these vertebrae get closer together, but it allows us to have an opportunity to where we can start to put compressive forces on the joint and also on the nerve. Because this nerve will extend down the body, we may have pain here, and we might also have pain down the length of the leg. That's sciatica. So degenerative changes in the spine can cause local pain, but they can also cause a referral type of pain, and we'll talk about that in the next couple of slides. Here to the right looks at the stages of osteoarthritis, and osteoarthritis means that we have degeneration of the cartilage that allows us to form unnecessary bone. We go through 3 stages of osteoarthritis. This one has 4, but there's really, three or four. We can argue on that. The first stage is the person has healthy tissue, okay, good joint spaces, good continuity between the bones above and below. The second one is we start to lose some of the joint space. We start to get the hallmarks of inflammation, and we may have some early signs of damage to the cartilage itself. As we go to the third one, we definitively have thinning of the joint space. Now we have demonstrable changes in the cartilage, and we're starting to see a little bit of signs of new bone formation that we call arthritis. And ultimately, in this stage 4, the cartilage is pretty much gone. We're bone on bone. We have deformation of the bony structure below it, and now we have new bone formation in arthritis. This is the person that clearly has impaired motion, can't move well, and has lots of chronic pain. Well, outside of the physical causes, what about metabolic and physiological conditions that can give us joint pain? And we're going to talk about chronic inflammatory pathways. I'm going to touch on gout as a cause of joint pain. We will look at autoimmune and infectious diseases. We'll look at iatrogenic causes. That means that things that are caused by modern medicine, things that we don't anticipate but are side effects of it. And ultimately, we'll talk about acid-alkaline imbalances and how your diet changes your metabolism to an inflammatory state. So this drawing does a good job to show you what the chronic inflammatory cascade looks like. As I said earlier, inflammation is extremely important for the healing process. The problem begins with an injury almost always. And as we develop the injury, then the body produces inflammation and messages through something called cytokines, okay? As the inflammation happens, it causes the body to lay down scar tissue in the form of fibrotic tissue and other mediators of inflammation. As we lay those down, it causes the local tissue to lose oxygen, called hypoxia, which accelerates the inflammation, and it feeds into this chronic inflammatory situation. So as you can see, we have a round robin that can go either direction. The ultimate thing is that we're seeing chronic inflammation in the body. This can be localized to one joint or certainly can be systemic in nature, but this is more or less how the pathway takes place. There's other mediators of inflammation, other types of neurotransmitters and hormones, but I think this illustration does a good job to give you an understanding of how the basic processes works. So the first metabolic situation that I laid out is gout. And the reason I chose that is because I'm starting to see this clinically more often in my practice. And if it wasn't becoming significantly more prevalent, you certainly wouldn't see TV commercials touting medication for gout. So our diet becomes an underlying issue in the gout situation. And more or less what it is it's an arthritic condition related to the excess production of something called uric acid. And the classic hallmark is we have an attack of sudden burning pain, maybe stiffness, some swelling of a joint, most commonly in the big toe, but it can also be in other joints. I've seen it many times in knees, but classically we see it in the big toe. This situation is very common in folks that have a purine-rich diet, such as eating excessive meat, seafood, alcohol, and refined foods. It used to be called the King's disease way back when, because only people who could afford rich foods like meats and alcohols would get it. As time goes by and we get repeated gout events, then we start to see the body will deposit crystals into the joint space themselves. And here on the right hand side, you can see this person's big toe, and as the body continually has these gout flares, it lays down this uric acid crystals which attach to the bone and more or less cause it a form of arthritis. Well, not only does that cause pain, these types of lesions are very destructive, so it will cause the joint to deform itself. And as it continues, then it's going to cause collateral damage to the blood supply and all the connective tissue around it. So it's really a bad scenario that can be prevented just by making sure that your diet is cleaner than you think it is. Conventionally, we see it treated with anti-inflammatories and what we call uric acid disruptors. But I think that the best way to handle it is just to make sure that your diet is clean of those things. And make sure, everything in moderation. If there's a family history of gout, then you're probably going to have a little predisposed scenario here. So always think about gout when you have unresolved pain. In certain situations, when folks have chronic inflammation, it may be due to an autoimmune condition, rheumatoid arthritis, psoriasis, those types of things are a constellation of diseases in which the body produces antibodies to connective tissue and other organs, resulting in inflammation and ultimately destruction of tissues. Some disability definitely occurs in 50 to 70% of individuals after about a 5-year onset. For the most part, we're not exactly sure why this starts, but there's certainly models that indicate that there might be a genetic trigger. There might be a chronic bacterial overload or a viral overload, and there's certainly some camps that say that there's a hormonal imbalance, maybe the increase in estrogen over progesterone that might propagate this. Currently, we see that the treatment is focused on immunosuppressive drugs and anti-inflammatory medication, so symptom relief. And as we go through later today, we're going to talk about how we can modulate the inflammatory pathways and the immune system to make these autoimmune conditions less expressive. In other words, make them less likely to express themselves. New to the block, certainly within the last 20 years, is the talk of infectious conditions that can cause chronic pain. The two biggies that I really picked out were mold and fungus. So when we start to accumulate mold in the body, either being an environmental mold, a black mold that you hear about in buildings and stuff like that, or enterically inside of us, a candida, the problem is that these molds produce mycotoxins, and mycotoxins are, as it says, it's a toxin which alters immune responses and increases inflammation. So as we are more and more exposed either internally or externally, or sometimes from both environments by molds, we see that the immune system has to get quite creative to try to figure out how to handle this. And in many cases, what it'll do is it'll just upregulate itself and overexpress itself, which causes that chronic inflammatory cascade. So the common symptoms are fatigue, GI complaints, brain fog, and definitely joint pain. The same can be said for tick-borne diseases like Lyme's, sometimes intestinal parasites, chronic viral overloads. They also upregulate the immune system and propagate inflammatory pathways. The same denominators are as we get these fatigue patterns, we can sometimes get rashes and definitely joint pain. And in cases of folks that have viral loads or Lyme-based loads, then we're going to see a neurological change as well. Well, we probably should include environmental contaminants in this scenario as well, because this is becoming more prevalent as time goes by. Our society is more toxic now than it certainly was 20 years ago, so we're going to have more exposure to chemicals and heavy metals and what we refer to as endocrine disruptors. Chemicals and heavy metal exposure include mercury, lead, cadmium, and aluminum, but certainly also things that we might not think about. The chemical constituents of plastics and petroleum products. Okay, so if you look on the bottom of a plastic water bottle, there's a number on there, and that number indicates how permeable and how much leaching of chemicals come out of the plastics. So the industry knows this is a problem. They tell us this, but they don't give us the answer key to the number on the bottle. So plastics are a big issue when it comes to environmental contaminants. Certainly pesticides and insecticides are a big issue. The more that we treat the crops, then the more that we're going to have this in our foods, and ultimately those substances will change the way our physiology and inflammation work. And then the food additives. This is a no-brainer to me. MSG, NutraSweets, all of those types of things, artificial colors and flavorings, they are contaminants. They are disruptors of normal physiology. So if you're eating those, you're definitely going to have a load response, and that might be chronic pain somewhere in the body. And the endocrine disruptors are chemicals that we get exposed to that physically and metabolically mimic estrogens. And the one we typically talk about are what's called xenoestrogens. So those are actually in foods like soy. It could be in tap water. All of the birth control pills that ladies take when they urinate and it gets flushed down the toilet, most of the time in a big city, that water is reclaimed and it's processed. Well, they only process it really to get the bacteria out. It's very hard to get the hormones out. So that's why they tell you not to flush your medications down the toilet. So we're getting it in the tap water. And again, like I said, plastics, they're a big source of xenoestrogens. A little tidbit here, if your kids like to freeze their bottles or Gatorade bottles before they go to practice, we actually now know that liberates the estrogens much more so than if we just left it at room temperature. So don't freeze the water bottles. It's probably best not to have the water bottle, but if you're going to have it, don't freeze it before the kids go to practice. We also know that we have bovine growth hormone and other additives to dairy and milk. So those are endocrine disruptors. It's in our cosmetics, okay? Phthalates. These are put in there because they actually modulate our hormones, so they can make us look younger. But the manufacturers often don't tell us that those are in there. And it slowly starts to mimic hormones in our body, but that can be counterproductive, and in certain cases it can cause some pain syndromes. And also Teflon cookware. Teflon, we've known for a long time, is a toxic substance. So anytime we have toxicity in the body is going to try to get rid of it, and it usually does that through inflammation. Iatrogenic causes. So this is something that we don't think enough about, that we probably should think more about. And I'm going to start on the right here, because this is something that I see time and time again in my office. The side effects of drugs, specifically I underlined statins, and I bolded it and made it bigger. The classic side effect of a statin, and this, for those who don't know what they are or don't take them, a statin is a cholesterol med. And what statins do is they block the production of cholesterol, but they do that by stopping the process halfway through. And when we stop it halfway through, it blocks something called coenzyme Q10, which is absolutely essential for the metabolism of normal muscle. So the classic side effect of statins is muscle pain. So I will often find folks that have on again, off again pain patterns that they never had an injury. They have no idea what it's coming from. And when I look at their medical history and look at the medicines they're taking, they're on statins. And the first thing that I tell them is, you need to go back to your doctor and talk to them about this, because we need to definitively rule out if you're having a reaction to it. And I'll tell you, more times than not, the person is having a reaction. The same thing can hold true for what's called proton pump inhibitors. That's for reflux, certain depression meds, and we can just have an outright interaction between two different medications. Your best bet is, if you're on more than one medication, find yourself a good pharmacist. Talk to them about what you're taking, because they often can give you a lot more information on if certain drugs get along. And if you're seeing multiple practitioners, let's say you're seeing a GP, a cardiologist, an endocrinologist, very often they're not looking at what the other person's doing. So a really good pharmacist, preferably what's called a compounding pharmacist, would be a great avenue, can help you understand if you're having drug interactions. And for many medications, it dumps all of our electrolytes. So when we lose our electrolytes, for example, with a diuretic, then one of the cardinal signs is that we start to get muscle cramping. So definitely look at what you're putting in your mouth. On the flip side, we can see medical procedures can cause issues. And for those folks who are listening to this that maybe have had a back surgery, I want you to know that 20 to 40% of most low back surgeries are failures, meaning that it didn't change anything, or maybe it worsened it. And The classic way that they fix it is by using something called a spinal fusion, which means that they're more or less taking two vertebrae, or maybe three, or maybe four, and they're locking them together by putting a plate in there and some screws. The issue becomes when you stabilize these structures, which are physically designed to move, then you are displacing that movement to the segments above it and below it. So in other words, you're just kicking the can down the road. You're stabilizing that area that causing you a problem, which probably will feel good on the short term, but as time goes by, 6 months, a year, 2 years, then you're going to start to form the issue above it or below it. And ultimately, when we have any type of surgical procedure, we're going to form scar tissue and adhesions. So for some people, they form much more scar tissue than others, and that's why they don't respond well to any kind of surgery, specifically in a smaller area. So carpal tunnel being one of them. There's not a lot of room in the wrist, so when we have procedure done there and we form a lot of scar tissue, we could be right back to where we started from. All right, how can we change this pattern of inflammation by changing what we eat? Well, it's called acid-alkaline balancing. And when we eat, the residue of the food metabolism leads to the formation either of what we call an acid or alkaline ash, okay? So if you increase the consumption of acidic-forming foods, you're going to shift the body to an acidic state. And towards the end, I'm going to show you a continuum of foods that are very acidic to foods that are very alkaline. So the take-home message is, as you eat further down the pathway of the alkaline, you're going to produce more alkaline ash, which is less inflammatory. So prolonged acidity depletes the body of buffering minerals and raises systemic inflammation. So if the body is in an acidic state, it has to try to buffer it and bring it back to neutral, and it's going to do that by utilizing stored minerals in the form of calcium, magnesium, potassium, and so forth. And it's got to bring those out of reserves. Well, guess where that all comes from? Most of the time, connective tissue. So if we already have an arthritic knee and we have a very acidic diet, and now we're starting to buffer it by pulling calcium and magnesium from an already degenerated joint, you can see how it's just going to make it worse. With time, this chronic acidity can start to affect multiple systems, and it, in many cases, can be what I call a Trojan horse for other diseases. So as you stay acidic for longer periods of time, it can cause a constellation of different issues. And you can see from this drawing, there's just lots of things that are associated with chronic acidity. So always think about what you're eating as it relates to your problem. And certainly if you experience aches and pains the day after eating certain foods that you know you shouldn't, then you really want to look closely at that, because this might be an acid-alkaline balance issue, or maybe even a food allergy issue. So the third pain pattern that we're going to talk about is what we call referred pain. And referred pain means that the pain is coming from a different area than where you feel it. So we're going to talk about what's referred to as dermatomal pain patterns. That's nerve compression. Sclerotomal, that's when you start to irritate joints and ligaments. Myotomal, that's when we start to have irritation and trigger points forming in the muscles. And then viscerosomatic. Viscerosomatic is when we have pain that's being projected from an organ system itself usually because of lack of blood supply, compression, or chronic inflammation. The first two referred pain patterns we're going to talk about are the dermatomal, or nerve compression, and the sclerotoma, or ligament compression, because they can mimic each other. For any of you folks who are listening that had nerve compression or herniated discs or those types of things, you know what this is all about. So this is called a dermatomal pain scale, and if you look on here, you're going to see that it relates to different spinal segments, C3, 4, 5, 6, 7, all the way down to T1. So let's say, for example, this person has a herniated disc at C5, okay, that puts pressure on the C5 nerve root. Well, they're going to get pain down the length of the arm, or numbness or tingling or weakness, or maybe even some other changes in the skin. Where on the other side here, if a person just has irritation to the ligaments in the joint itself in C5, this person is most likely just going to have pain throughout the neck. Well, unfortunately, it's fair game for a person, and most commonly, especially with folks who are older, to have both of these occur at the same time. So the person will have old-fashioned neck pain because the ligaments and the cartilage are getting irritated. That's the sclerotome, and because the disc is putting pressure on the nerve itself, we will get a referral of pain down the arm as well. If we get hyperirritability of muscles and we develop things called trigger points, so a trigger point is more or less just a knot in a muscle, and we have all experienced those. If you feel around in your muscles, for example, like your trapezius muscle, that's a muscle that goes from your head to your shoulder, and you start poking around, you can feel little tiny nodules in there. Those are called trigger points. So in this picture here, okay, this muscle group has X's in it, and these X's relate to trigger points. So when you put pressure on this trigger point or you irritate this trigger point, it causes the pain to refer down the arm. Well, isn't that interesting? That's kind of similar to when we saw that last slide that showed that person that has that C5 nerve compressed. So for some folks that have arm pain, it's not coming from a disc protrusion, even though maybe the MRI shows it's protruding. It may be coming from just having a trigger point. So you want to make sure in this case that you can reproduce the person's pain. And so there's orthopedic tests that will help us understand that. This is the classic scenario where the person will have arm pain, have an MRI. MRI will show a disc that's bulging, that's kind of on the verge of being problematic, but the doctor says, yep, there's your issue. The person will get surgery or have a procedure done, and it doesn't change their arm pain. The reason being is the disc wasn't significant enough to compress the nerve, and this person truly had referred pain from the muscles, so it's a myotomal problem. So you want to make sure that you have an orthopedic evaluation to help determine if it's coming from the nerve root versus coming from the muscle itself. On the right side, we can get viscerosomatic pain, meaning that as our organs become irritated, and as I said before, it's usually because of lack of oxygen, maybe some sort of compression, or maybe a chronic inflammation, then it's going to express itself by causing pain throughout the body. I'll start with this distribution. So this is the heart, and as you can see, when we have a heart issue or a heart attack, then yes, a person's going to get chest pain. But also, look, it's possible that the person might get pain down their arm. Well, isn't that interesting? That looks very similar to a person that might have, again, that disc problem in their neck that causes pain down the length of the arm. For folks that have chronic back pain, notice this, the blue section that almost looks like a saddle here. This is the distribution of the kidney. So we might suspect, well, if the kidney hurts, I get pain just here. Well, it could be that we're getting pain down the side of the leg, and maybe we're getting pain in the groin. So never forget that the organs will refer pain. When it comes to the visceral referral, this is the scenario where the person typically can't make it a lot worse or a lot better by moving or doing anything. It's something that's kind of always there. So if your pain pattern is relatively chronic and it's non-provocative, then you might want to dig a little bit deeper into the visceral component that may be causing it. Okay, we went through a lot of different scenarios. So how do we test for these things? Well, we certainly want to do a thorough history. That's probably the most important component of any medical contact. You sit with a patient, you ask them how long it's been there, what makes it better and what makes it worse, and 90% of the time they're going to give you the information you need to make a diagnosis. These tests that we're going to talk about are to help you confirm what your thought process is. So If we're concerned that there's an injury to soft tissue, then we are going to look at an MRI or something called real-time ultrasound. These allow us to look at the muscles, the ligaments, and the tendons to make sure that we haven't damaged those. If we're going to look at old school arthritis or degenerative situations, then an X-ray, a CT, or even an MRI, these are the gold standards that we use to help quantify that. If we have a suspicion that there's an autoimmune or infectious disease that's taking place, then we are going to look at autoimmune markers, something called ANA or RA factors. We might do what's called a Lyme panel. Lyme panels are very much a gray area because most folks that suspect that they have Lyme might have been exposed many years ago. So unfortunately, in many cases, the conventional Lyme panels are not that valuable. And there's certain DNA fragments that we might want to look for other types of pathogens that we've been exposed to. And ultimately, we want to start with what I underlined here. These are the blood markers of inflammation. So the next few slides that we're going to talk about is, okay, what kind of markers can we get tested when we have our annual blood work through our primary care or whoever that can tell us that we have inflammation in place. When you get your annual exam, they often do something called a CBC, a complete blood count, and part of that looks at the white blood cells. So your white blood cells are really actually a good indication of how inflamed you are and how active your immune system is to control the inflammation. And the white blood cell count is broken down into subsets. The first one is something called a monocyte. And monocytes are there to clean things up. They get rid of damaged cells, they get rid of bacteria that shouldn't be there. So they're like little Pac-Man. They go around and eat things. So they have a longer lifespan than many of the white blood cells. So if we have an elevated monocyte count, that could be an indication that we have a chronic infection or chronic inflammatory state in place, meaning that the monocytes are just constantly having to go around and clean up the damage that's occurring either because of the inflammation or because of chronic bacterial infection. The second one are what we call the lymphocytes. And the lymphocytes are what create antibodies to help fight against bacteria, virus, and other pathogens. These guys are a little bit more active in chronic disease. So as a virus sets up shop, it takes a little bit of time before our body can fight these by producing antibodies. So as we start to fight them over longer periods of time, we see a shift and we start to see an increase in the lymphocytes, where the next category, or the neutrophils, are the ones that typically are the first on the scene to arrive. They kill and they digest bacteria and fungus, so they're a first line of defense and more so an indicator of the acute situation. So if you start to see a shift in the neutrophil to the lymphocytes, so it should be about 60% neutrophils and 30% lymphocytes, right in there. So if you start to see that gap close and get close to 50-50 or maybe even invert itself, then it's suspicious that we might have a long-term infection or inflammatory state that's taking place. The basophils are important because they help sound an alarm when an infection is present. So they tell the body, hey, there's something here, we need to do something about it. And they do that by producing chemicals such as histamine. We've all heard of histamine as far as an allergy reaction, and we take antihistamines as well. Well, what is an allergy? An allergy is the body's perception that there's a foreign agent. Okay, and that's an antigen. So an allergy is an immune response, and it's the overproduction of histamine. So histamine is a messenger that tells the body to upregulate the immune system. The issue becomes if we produce histamine chronically, then we get this inflammatory cascade that causes all the classic symptoms that we're aware of when it comes to allergies, the sneezing, the runny nose, maybe I can't breathe, all of those types of things. So histamine on the short term is fine, but long term becomes really counterproductive to just day-to-day living. And also we look at the eosinophils. They attack and kill parasites and also cancer cells, and they can help with this allergic response as well. So your white blood cell count is a good start. So even though your numbers may be in range, okay, you want to look at the percentages. So talk to your doctor about that and what that means. Well, if we're going to add things to our annual blood work, to help us understand if we have inflammation, then these are some of the things that I would definitely have your doctor run for you. So get a pen and write these down. If we want a general assessment of how inflamed we are, there's two markers that we classically use, something called CRP, C-reactive protein, and something called ESR. They tell us that there's a fire somewhere in the house. They don't tell us where the fire is, but they tell us that the fire is present. So this is kind of the smoke detector. This is a great baseline test for inflammation. And again, it doesn't tell us what it's coming from. It just tells us that it's inflamed. The one thing that I'm going to throw out here when it comes to CRP is this. We definitively know that fat cells produce these inflammatory markers. And I'm seeing more and more with my patients who are overweight that they have chronically high CRP levels. So they have these high markers of inflammation, not because they have an autoimmune disease or Lyme's or what have you. It's because their fat cells are producing the inflammation. But like anything else, inflammation over the long haul is not good. So people who carry weight, not only is that bad for your joints, and that makes sense, but it's bad because we chronically produce inflammatory markers, which causes the immune system to go out of range. So CRP and ESR, I really like those as a quick screen. The next one I like is something called fibrinogen. Fibrinogen more or less tells us how sticky our blood is. So the stickier the blood is, the more it's likely to coagulate and clog and clump things up. So if you want a good indicator of inflammation as it relates to the cardiovascular system, then fibrinogen would be a great one to add. I would specifically add this one in if you've had family history of heart attacks or strokes, or maybe you've had them yourself. You want to know how sticky the blood is. And this is not the same as clotting factors. So if a person is on heparin or Coumadin or Plavix or those types of things, that's for physically clotting of the blood. That's a little bit different. This looks at just how sticky the blood is and how more or less how gelatinous it is. So fibrinogen, that's a real good one. We talked about uric acid. I see lots of subclinical gout walking around. In other words, the person has high uric acid and doesn't really have any significant chronic joint pain. So you want to have that checked, because if your diet is not where it should be for your physiology and you're producing a lot of uric acid, it's going to cause inflammation and ultimately irritation. The next marker I like to look at is something called homocysteine. And it's a marker for vascular inflammation. As we inflame and we start to irritate the blood vessel walls, then the body has to repair it, and that's what it uses cholesterol for. So in itself, cholesterol is relatively innocuous unless it has something to do like repair a vessel wall. And the next test, the VAP cholesterol test, would be the preferred way that I would test cholesterol. So conventionally, when we have your cholesterol checked, it looks at HDLs and LDLs and total cholesterol. Well, that doesn't give you the big picture. There's something called a VAP test, and it looks at all of the subsets of the HDL and LDL, which tell us how inflamed we are and really how significant the elevations are in our LDL. Just because we have a high LDL on a conventional cholesterol test does not necessarily mean that it's bad. So you would want to expand to that VAP test. So we want to add that into the annual panel every year. The next marker that I may check for, and this is not what I wouldn't add this guy in on just a routine exam, but I would definitely add this in when the person is experiencing just lots of pain for no reason. It's something called creatine kinase. As a muscle cell die and repair and do their thing, which they do, all cells die and then repair themselves and come back, they release chemicals and enzymes, one of them being creatine kinase. And as the muscle cell dies, this enzyme gets into our bloodstream, and there's a normal process that takes place. So you should have a certain level of this enzyme in your blood. When it's elevated, then it's indicative that we're causing irritation and inflammation to the muscles beyond their capacity. So the muscles are dying prematurely. So this enzyme is what you would want to check if you're suspecting that your statin drug is really causing problems. And if this number becomes high enough, then the diagnosis is something called rhabdomyolysis, where the muscle is literally melting. So for folks that have chronic muscle pain and they're not so sure why, I like this test. When we go down a couple slides from now, we're going to look at the way nutrients impact the body's physiology and immune system. So if we don't have enough of the raw materials or ingredients, we can't make what we want to make. So nutrient testing becomes really important. We want to check your vitamin stores, your mineral stores, your amino acids. If we don't have ample vitamins and minerals, then biochemical processes can't move forward. So nutrient testing becomes very important for some folks. Adding to that, we might even want to consider allergies, food allergies being the biggie for me. Conventionally, we see food allergies tested through something called IgE, and that's an immediate sensitivity, but we also will check for something called IgG. That's a delayed sensitivity. So this is the irritation that might be caused by the food 24 to 72 hours later. So food allergy testing can be a really good way to determine if what you're eating is actually helping your immune system. And lastly, I'll often look at something just as simple as a urinary pH. I talked before about acid-alkaline balancing. Well, if we're always in an acidic state, it's eventually going to change our urinary pH. So it's the end product of metabolism. So at home, if you have some pH paper and you check your first morning urine, and if it's always very acidic, anything below 6.8, 6.5, then that's a little too acidic. That indicates to me that your body is chronically in an acidic situation. So buffering minerals and a better diet would be a good start for that. Well, there's certainly other tests that we can add in besides blood tests, and these look more at what I refer to as the biological terrain. The biggies are, as we would look at adrenal function, that would be the cortisol rhythm. Cortisol is an anti-inflammatory hormone produced by the adrenal glands, and if we produce too much or too little, then it greatly impairs our ability to control inflammation. And because cortisol is responsible for modulating the immune system, then it can affect that as well. Fatty acid profiles, omega-3s and omega-6s. We all know about the importance of the omega-3 fats, and I'm going to show you a diagram in a second about how that works. So we can test those. It doesn't matter that you take a whole bunch of fish oil every day. Your omega-3 level might not be where you think it is. So the best way to handle that is to check it and see where you are. There's very good lab testing that can show you exactly how high or how low your omega-3 and 6 levels are. If we're considering there might be a underlying digestive problem, then we can do something called a comprehensive stool analysis. It looks at how functional your GI tract is. Is it inflamed? Is there good bacteria? Is there bad bacteria? Do you produce significant enzymes to break down foods? Everything begins with digestion, so if we're not digesting and absorbing, it makes it really hard to run the machinery and the day-to-day operations, and ultimately the immune system has to handle all the byproducts of that, and we often will see that as an expression of too much inflammation. Hormones, both male and female, can be very important for folks that have chronic pain, especially folks who are a little bit older. If we're starting to see a lag in testosterone or imbalance in estrogen or progesterone, it can accelerate the degenerative process, and it can actually propagate inflammation as well. So always consider looking at hormones as a component of why your inflammation is just staying pretty stagnant. And if we're interested in testing for heavy metals, then we can do that either through hair or a urinary challenge, meaning that we can take a chelating agent over the course of 24 hours and collect our urine and see if we're physically harboring or holding any metals in our body. So these are other tests that are really good to look at the biological terrain. I think these have tremendous value to add into your annual exam. Again, it really depends on what your symptom pattern is, but I think most folks every other year, if they're relatively healthy, should do hormone panels and adrenal panels. And I think everyone should probably, during the course of their life, do a stool test, regardless if they think they have a digestive problem or not, because you'd be really surprised at the imbalances that take place in the digestive tract, and you might not even know it. Okay, so we went through a lot of things. So let's try to put these puzzles, pieces of these puzzles together to try to give you some answers and give you some strategies how to handle these chronic inflammatory situations and these pain patterns. Ultimately, what you eat is what makes up your body. So I spoke earlier about acid alkaline foods, and this is really a pretty good illustration of where different foods lie on the scale. So in the middle of this drawing is 7. So let's just say that is smack dab in the middle. And the optimal zone would be between 6.4 and 7.4. The best way, again, to measure this would be through your urine, because that's a great indication of how well you're buffering. So if we eat foods on this end or have activities on this end, then we're going to have a tendency to be more acidic. The biggies are the white breads, alcohol, sugars, and all that type of stuff. Well, guess what? If we don't sleep, we have stress. Remember I talked about the obesity that produces CRP. If we don't breathe right, then it has a tendency to drive us to the acidic side. Where on this end, if we eat more of the veggies and the fruits, the nuts, the healthy oils, we get good quality sleep and all those types of things, we drive the pathway to the alkaline side. We oscillate back and forth all the time, and that's important. Sometimes we want to be acidic, sometimes we want to be alkaline, but it would be better if we stayed somewhere in here as opposed to whipsawing all the way here and then going back all the way to this end. So think about what you're eating, think about your diet, and certainly think about habits like sleeping. I can't stress enough, if you don't get a good night's sleep, then you're really coming out of the gate 2 steps behind. All right, for all those folks that want to talk about taking omega-3 fats, their fish oils, or taking omega-6 fats, this is probably one of the best illustrations I've seen to help you understand why they're important and also the limitations that fall into place. So this cascade looks at the production of omega-3 fats. This cascade looks at the production of omega-6 fats. And as you can see, you can go from omega-3 to omega-6 back and forth. But what I want you to really look closely at is, in order for these steps to go from one to the other to take place, we need these enzymes, okay? And these enzymes are dependent on these nutrients or cofactors. So these are what we refer to as a rate-limiting nutrient. So if we don't have these nutrients in the amount that we need, then it becomes real difficult to go from one side to the other. So for folks that eat lots of omega-6s, or maybe even supplement with it, let's talk about flaxseed oil. That's an omega-6, okay? So if we're taking omega-6s up through here, and we're hoping that they get converted to omega-3s, we're seeing that we have to go through all of these steps. So there's a lot of room for error. Where if we just take the omega-3s, we are already in this column. So I am a big proponent, when possible, and I understand some folks are vegetarians, I'm a big proponent, if you really want to express the omega-3 side, then you should take the omega-3s like a fish oil, because fish oil has EPA in it, eicosapentaenoic acid, and DHA, docosahexaenoic acid. So by taking the fish oil, guess what? You're already halfway down the pathway to what? Your anti-inflammatory hormones. So look at this, anti-inflammatory, anti-inflammatory. So you're already there. There's a lot less to go wrong. Now, if you're taking the omega-6s, guess what? If we can't go this way and we continue to go this way, then we can produce pro-inflammatory mediators. That's why a lot of the omega-6s, like the grains, are very inflammatory. It's interesting to note, you see where it says here COX and LOX, COX and LOX? This COX is COX2, this one is COX1. COX2 is the enzyme that converts us to the inflammatory markers. This is what Advil and many of the over-the-counter medications block. So they block this pathway. Okay, so there's bad COXes and something called LOXes. So from the take-home from this slide is, if you really want to manipulate your omega-3s, your best bet would be to be lined up in this category. Okay, yes, you can convert it over, but it is asking your body to do a lot of different things, and you need these cofactors. So before you're concerned with taking lots of flaxseed oil or evening primrose or those types of things in hopes of controlling inflammation. Now remember, I'm talking about it as far as inflammation. There's other reasons that you would take omega-6s, borage, flax, and that's for other things, for skin function. But if you're purely taking it for its anti-inflammatory effects, you'd want to stay in this category. Well, we would be remiss if we did not include in this slide nutrients that you can take for pain and healing. I broke it down into different categories. My favorites for anti-inflammatory, which would be the essential fats. We just talked about that, EPA, DHA. That's the omega-3s. If you really wanted to take an omega-6, the GLA, it's a little bit further down the pathway, so a little bit closer to getting to the anti-inflammatory side. Bromelain and papain, these are in papayas and they are in pineapple. These are anti-inflammatory nutrients. You would take these on an empty stomach. And we've all heard of curcumin, which is in turmeric. These are very well known, been utilized for centuries as anti-inflammatory. So I'm a big fan of those. If your concern is to support the cartilage and your joints, then you would look for things that physically donate sulfur or sulfite ions. Chondroitin sulfate, glucosamine sulfate, MSM, and there's a micronutrient called molybdenum that is very important for all of these ingredients to bind and to do their things. If you suspect that you have an immune-related issue that's propagating your inflammation, then you might want to look at different forms of mushrooms, maitakes, things like that, adaptogenic herbs, rhodiola, ashwagandha, schizandra. These all help to modulate the immune system and also the hormone system. And lastly, if you suspect that there's a bacterial or a parasitic or a fungal situation, first and foremost, you should try to test for that if possible. If you're considering using a natural agent, then things like grapefruit seed extract, oil of oregano, caprylic acid, these are very antibacterial and parasitic, and they work well. Again, you'd want to test for these because some of these will also kill off your good bacteria in your gut. So you don't want to try to eradicate something unless it's actually there. Well, to wrap up, I almost always put this slide in all my presentations because it doesn't matter if your issue is you just tore your rotator cuff or you've got rheumatoid. You need some steps to success. And the first one is always knowing your pain type. So think about it. Where do you fall on that scale? So go back and look at that slide again. Where are you on that? What kind of tests can you do to confirm it? Both laboratory radiology and those functional biological terrain tests. Where are you right now? What can you do to improve your nerve function, both local? If you have nerve compression in the back, you better decompress that nerve. And if you have autonomic issues, another member where the sympathetic nervous system is overactive, you've got to come up with strategies to calm it back down. If joint function has been compromised and it doesn't move, you need to either manipulate or mobilize that joint to make it move better. Motion is lotion, so as we start moving, then the joint is going to further deteriorate. If we have any form of muscle guarding or scar tissue, then we have to get rid of that as well. So soft tissue techniques are extremely valuable. What can we do to break up the scar tissue? What can we do to restart the biological terrain, digestion, detoxification? And lastly, what can we do to reduce systemic inflammation in the form of acid-alkaline balance? Go through these steps. Ask yourself, where do I fall? Do I have problems in my nerve function? Do I have it in joint function? Do I have it in muscle guarding? Do I have bad biological terrain? Do I have reduced inflammation? And ultimately, what is my pain type? and ask yourself, what are the things that I can do to help delineate where the problem is coming from, so I can implement things that will physically fix the problem. So if we put it all together in our office, we often look at this illustration. It's called the triad of health, and it's the structural, chemical, and emotional things that affect us. So there's lots of modalities that can help restore our health. And if you only work from one side of the triangle, let's say chemical, and you're just doing anti-inflammatories or injections, you're going to miss the other two sides of the triangle. So ultimately, your healthcare provider should work from all three of these platforms. So they should be able to improve your structural health, change your body chemistry, and ultimately impact the way that your mind is working. In closing, we went through a lot of different concepts today, and I encourage any of you folks who are currently patients of mine, pull me aside, or if you're patients of another doctor, pull me aside if you have any questions, and I'll be more than happy to go through any of that. If you have any other questions, you're not patients, you can feel free to call the office and let us know how we can help you. You can also email me if there's questions if you're not in the area. For those folks that are here in the Nova, Northern Virginia area, and you need a little bit more assistance in person, then our office works ongoingly with an organization called Caring for Others that helps folks in need. And we do these outreaches a couple times a month to allow folks to get answers to their health problems, but also generate money for the charity. If you want to come in, you want to sit, you want to talk, you want to review your labs, you want to make sure that you have what you need, or maybe go in a different direction, then for $99 you can come into the office and sit with me, do a full evaluation, review what you've already had done. I'll probably make some recommendations on some further testing, and we can get some more data. And at that point, it becomes easier to give you options on how you can conservatively treat your problem, change your health, and certainly impact your wellness moving forward. So for those of you who are interested, please feel free to call us at 703-698-7117. And for those of you who have questions, feel free to contact me at the office at any time, or grab me in the hallway. Next week, I think we're 2 weeks from now, there'll be another presenter with another topic. I will be back here doing the same thing in November. So go to our website, keep an update on that, and let me know if you have any questions.